Welcome to the Quality Measurement in Health Professional Education, Revisiting the Metrics, our international conference, which I'm very pleased that kicks off today with the pre-conference workshops. Assessing the quality of health professional education interventions is a task that appears more difficult than the comparable task with clinical intervention. What to measure, how best we can measure it, and so what are important questions we are struggling and trying to find answer to it. Aim of this conference is to create an opportunity for health professionals, educators, regulatory bodies, healthcare authorities, public and private healthcare services providers to interact with experts in the fields of quality and assessment, share experiences, and how to introduce new assessment methods in their own contexts. The speakers are scholars and leaders of innovations in health professional education. The conference will be an excellent opportunity to meet, discuss, and exchange opinions and best practices in the field of assessment and program evaluation. It gives me a great pleasure and honor to present two dear friends, Professor Trevor Gibbs, President of the Association for Medical Education in Europe, AMEE, and Professor David Taylor, Professor of Medical Education at Gulf Medical University. They are not only my friends, but at the same time, they have influenced medical education for the last quarter of a century, I would say. And today, you will be listening and sharing with them their views about how medical education should move outside of the ivory tower. And the title of the workshop is Outside the Walls of the Ivory Tower, Using the Community for Real Life Assessment. A very interesting concept which can change how we teach and how we assess our students in a changing healthcare system, which is also moving from the hospitals to the community. Thank you very much, Trevor, and thank you very much, David, for accepting our invitation and for sharing with us your vast experience in medical education.
Very excited to start our workshop. Dr. David and Dr. Trevor, the floor is yours. You may share your screen.
Thank you, Iman, and thank you to Osama as well. It's always wonderful to see him, and hopefully I'll see him in a little bit different light and in a different speech tomorrow. Thank you, everybody, for attending this workshop, and I will emphasize the value of a workshop later on. It is a work, and the word begins with W, work. That means that you do all the work, and David and I help you do all that work. My name is Trevor Gibbs. As Professor Hamdi said, I'm the president of AMEE, but for this workshop, I like to think myself more as a working general practitioner, well, a retired working general practitioner, if there's any one of those sort of things. Most of my clinical life was spent in general practice, some of it working with David in developing the Liverpool curriculum. David, would you like to introduce yourself before we move on?
Yes, I'm David Taylor, and at the moment I'm speaking to you from near Liverpool. Normally I would be talking to you from Gulf Medical University, but COVID means that I'm not there and I'm here. Delighted that you've been able to join us. I'm slightly distracted because I'm allowing people into the waiting room. Sorry, that there was the mix-up about the timing of the workshop, which clashed with it meant that we were going to clash with 3 other workshops, and so we reverted to what was for us the original planned time of 3:30 UAE time. We've got plenty to say, we've got plenty to do. It is a workshop. It's not going to be a series of lectures, and Trevor's going to lead us through the first part, and then I'm going to be doing the some stuff with you when we've got to the stage of breaking it down into groups.
Thanks, David. Yeah, I think first of all, let's explain a little bit why we are giving this workshop. Almost the first time that David and I worked together was when we were in Liverpool together, and I was what's called Director of Community Studies, and David was holding a much higher position in Liverpool than then. He was running the whole curriculum, I've got to say, at that point. And with me being a general practitioner from the UK for many, many years, I was very honoured to take up the position, which meant that we were taking, my job, in fact, was to take the students out of the Liverpool ivory tower of the university and get them learning healthcare within the community. And it made me at that point realise that communities are both different and the same for different countries, you know, sort of. So we have similarities in different countries and some big differences in different countries. And that was then sort of strengthened by my visits to many other countries around the world about what is a community. It also made me realize that there were many more opportunities for learning in the community than the standard practice of general practice itself. There were many more opportunities. So really one of the things that I want to do, or we want to do, sorry, is really look at this concept of community and see how we can use it. So if we've got any learning outcomes from this session, it's about all of us understanding the various meanings of a community, understanding each other's community and the learning opportunities that it creates, and let's explore the assessment opportunities that exist within the community. Now, as David says, we're not going to sit here and go through a massive slides of what we think and what we've explored. That will come through discussion. I want this mainly to be a discussion type workshop where you do the thinking and chatting, and then we will try and pull it all together at various stages. So we will have 3 stages fitting in with these 3 learning outcomes. I'm noting that we've got 30 odd people on the platform at the moment, which means that we probably will be able to work in small groups. So will David, in his inimitable fashion, will be able to structure those groups, and then we'll get you working in those groups for a particular time, and then coming back and we'll try and draw each of the sessions together, ending up with the most important one, which probably has not been a lot of work done, of using the community as part of our assessment of the students. So if I can go on, let's first of all think about the meaning of community, and I'll show you later, but there are many ways to define the community. But I think it's important that we get you to think about, what is this term community? What does it mean to you? You know, as I said, we're moving outside the walls of the Ivory Tower, moving outside of the walls of the hospital, we're moving outside the walls of the university. We managed to use the community right from week 1 of our medical students joining Liverpool. So we must have thought of a community in a different way that many other medical schools did. So what we want to do is for you to work in your groups, and we'll give you about 10 minutes to do this. Just chat amongst yourself and decide what you think this term community means. David, are you okay with the with splitting into groups?
Yes, I've created 5 breakout rooms. In a moment, I'll press create. Oh, and Arena's joined us. I've pressed create, and then you'll get a message on your screen asking you to join a group. Please join the group, and we'll just come around the groups and make sure things are going well. So I'm going to create.
Okay, and then we'll be back in 10 minutes, hey, David?
10 minutes, yeah. Open all rooms. It's a question about the different sorts of definitions there are of community, and rather than distribute to other rooms, if you want to share that information amongst people that are here, then we'll be able to compare ideas when everybody gets back. Okay, so we've got most people are back. Can somebody from each group, we'll not necessarily go through all 10 groups or however many, 5 groups, or we can, can't we? I need somebody from each group to say what you think, where or what is a community? Who would like to start?
Good evening, sir. May I?
Hello,
Shiva,
Shiva.
sir.
Of course you can.
Yeah. Thank you, sir. To my understanding, community means it's a group of people with a common characteristic or a common interest, and they will be living together and they may be part of a larger society. And as per the Richard Millington, they are classified into 5 different communities. That is communities of interest or communities of action, communities of place, communities of practice like ours, communities of practice of medical educators or health professionals, and of course, some circumstantial communities also. Thank you, sir. Thank you.
Okay, then Shiva, yeah. Somebody want to add to that? I mean, it is a group of people, and I know that was one of the things in group 2 as well. Something else?
Group 5, we want to add little bit group 5.
Okay,
Shukri, actually our group was diversity, so there was doctors, nurses, and other professionals.
Sure.
So someone was just describing the community, which is like they have to be same interest, same geographical area. They have to have same characteristics, all these things. And the other group, like medical group, they were telling a community, it can be anyone who have interest. It's not necessary to be in a same geographical area. So there is a community medicine, there is a community this. So it depends, but if we are talking about the community, which is general community, it will be those who have a same geographical area. So that's all.
Okay, so something about geographical area. Okay, I mean, Shiva's definition was similar, wasn't it? Group of people with the common characteristics either of interest, action, or place, which is a known formal definition of community. Okay, Daya, who's speaking from your group? Who is speaking from group 2?
Yes, can I add my group definition of community?
Yeah, you, Dr. Gada.
Yes.
Good, gotcha.
I agree with the opinions mentioned by the other groups. We would like to add that we have considered it in the perspective of assessment and evaluation.
Sure.
We were discussing that we might include that definition is when the learners will be assessed or will be trained outside of the, let's say, the college setting or the university setting or any community that is not influenced by the university. So we were considering primary care hospitals, tertiary care hospitals where participants are included in those areas for training and assessment. And one of the opinions was simulation centers, which is the transitional phase from the university to the clinical practice. So that might also be included in the community learning, since it mimics the reality of what they will be facing in clinical practice.
Okay, thank you. Daya, or is it you, Dr. Al-Sayed?
Yeah, in
Good.
our group, we discussed the definition of community as the other groups have done, okay? And then we discussed where we can assess the students and teach the students outside our ivory tower, which is a university building and the university hospital. So we can do that in the primary health care centers. We can do that in the Ministry of Health hospital. We can do that through the troops which are going to, for example, for a mall or for a district area to do health education to the people, or to do some investigation, see the prevalence of diabetes among these people, okay, the presence of obesity and so on. So they do that in the community, yeah, outside, of course, the university premises. Yeah.
Okay,
Essential.
thank you.
Yeah.
Is there a group that hasn't said anything yet? I'll just briefly, while Trevor is thinking about how he's going to pull all that together, I shall just share my screen. I've been making notes, and so a community is a group of people with a common characteristic, interest, action, or place. Lovely. And then we've got a slight difference of opinions. It's where learners are being trained outside of the university setting. One of the groups included hospitals as being outside the university setting. And interestingly, you put in the simulation center. That is, and you're quite right. That is on the bridge between the two. And then we had the other answers of places like primary healthcare center, ministry hostels, local clinics, health education. And if I think of the university where I work, got a very strong pharmacy department. So I would say pharmacies, when people are out working in pharmacies, that's a good place, and absolutely clinics. So that summarizes. You notice I've got a very badly trained spider who writes my notes for me. I think I've done very well, but I can read them anyway. Somebody said something in the chat. Very big thank you. Okay, I'll stop sharing. Trevor, over to you, my friend.
Never mind you as a spider. You haven't seen my handwriting recently. Truth. Okay, that's been a good big discussion, because I think if I just whisk back or go to this, if you look at the community, people, as I said to you, I think one of the groups, people use this word almost as though everybody understands it. Let's go to the community. Let's use the community. What do the community think? But they actually don't understand that community. And if they do, very often they think about it from a pure medical healthcare perspective, as opposed to lots of other things. And I think one of the things that we want to do today is to make you think out of the box, think out of the traditional box, think what else is out there where your patients, your clients live and interact. If you look at the Oxford English Dictionary, it's all about just people living in one particular area, or people who are considered as a unit. but I'm not quite sure what that unit is, and if it is a unit, because it's so flexible and so movable and malleable that it can't be a very fixed unit. It's a unit, but it's certainly not one that say, right, this is it, and we can geographically define it. The WHO, quite a while ago now, tried to define it to a group of individuals together in a defined geographical area. I suppose that's getting a little bit closer, usually comprising a village, town, or city. But it's just about that group of individuals. And I think what we have to do is to think, well, there's a medical group of individuals and clients, our patients, but they're then another group of individuals who maybe don't use the hospital, don't use the university, but still have potential to think and train and talk to our students. And as David says, the pharmacies are growing now, and certainly in the UK, we have a situation now because of COVID, where it's very, very difficult to see a general practitioner at the moment. We used to be very proud of our open door policy, but that's not very good. So we're finding a lot of our patients, our clients, are actually going to the pharmacy for advice. We're also seeing a growing number of what's called NGOs or organizations or self-help groups that are helping people in certain situations. The biggest growth area in the UK has been the one that deals with post-traumatic stress syndrome, or actually what's happened with COVID. There are organizations now are dealing with people who have specifically lost their husband, their father, their son, their family member in COVID. But it's quite likely that these organizations can help. You also have to think, well, what about the patients themselves? They are part of the community, or just the people who live in that community. They are part of that community. Are they useful? What can they do? So again, it's really trying to move people out of that traditional semi-defined model of the community to one which has got a much wider use for our students and for our educating our students. If you look at a long, long time ago, there was this quotation from somebody, Lord Chesterfield: the knowledge of the world is only to be acquired in the world and not in the closet being a cupboard in those terms. You know, we can only use the world if we look outside of that world. For many, many years, the only world that a medical student or doctors or whatever used was the ivory tower, and that's why it's called an ivory tower. The hospital or the university, but surrounding that is a tremendous potential area of teaching, learning, and assessment. So the definition of a community has changed, and it probably is still continuing to change. Each university probably has its own definition of community. Many more health and well-being organizations existing now outside that university or hospital. David and I tried to put together the other day what we thought maybe was a definition of community. And this is not the gold standard by any means at all. It's just one that we put together. An holistic entity outside of the university and hospital in which our potential clients or patients reside, work, socialize, and seek advice. You have to remember that many people, before they come to the hospital, do actually seek advice, and that's where they may actually seek it from their family. I was born a long time ago. I was born in 1948, and I lived in a place called Nottingham, which was in the centre of the UK. And my grandmother, who was a nurse. She used to be the first person that anybody went to when they were sick. Never mind whether they'd broken their leg, whether they had headaches, whether they'd cut their finger, it was always my grandmother that they went to. And I thought this was fascinating. I never saw a doctor in general practice until I was quite old, because my family looked after me. Now, in some units, in some communities, that still exists. In some rural communities, in some of the countries I work in, that still exists. Should they be used in terms of the community for our students to learn from, for our students to talk to and learn from? We don't know, and we have to think about that. So I think when we come to start using the community, we've got to clearly define it before we actually then know what the potential is. So I think what we want you to do now, again, in the same groups, if it's okay with you, unless David wants to add anything else. David, did you want to add anything to what I've just spoken about?
No, I just want to split it into more groups.
Okay, I'll let you do that.
Create new groups.
And I think, if I want to, I'm just going to look in the chat room because it's interesting. Yeah, so Faris says all the components of a healthcare system that interact with the students, but it might not be the traditional healthcare system, Faris, that we're thinking of. We have to think outside of that box, because the potential for learning from our students is really outside of that box. Dr. Sheba says we have virtual community too now. That's great, yeah. Visual communities of learners or virtual communities of medical educators. That's true. Would you then define that as your learning community, or would you define that as your faculty community? I'm not quite sure. Titi said there's a virtual community of practice, virtual clinics. Sure, but that may not be within your community. There's a lot of virtual clinics that you can go even way out of the country to see. Let's keep thinking about the actual community that we've got, although I do appreciate the comments there. So if we're going to go into the groups again, what I want you to do this time is to try and discuss what we've just been speaking about, understand each other's communities. What is that you've got that another community hasn't? Like David said, he's mentioned a lot of pharmacies springing up now. Have you got that? Do you use them? Okay. Think about the learning opportunities that element of the community creates. And what I'd like you to do is think of it using the 3 learning domains. We often think about it as just the knowledge domain. But what about the psychomotor domain? Somebody's already talked about simulation in the community today. What about the affective domain? How do students learn about the ethics of care, the attitudes that people have about illness and disability? How do people value other things? How do they get that value? Does it come from the home? Does it come from the community, or is it always taught? So I want you to really open your brains and think out of the box for this. And I think we'll probably give you 15 minutes for this one, David. Is that right?
Sure.
Yeah. Okay. So let's go into those groups, and please do think about these different learning domains, because I think they will help you. So we'll see you back in the big group in 15 minutes.
I've split you up into more groups so that there is only 6 or 7 in each group. So that means you're going to be with new friends. And yes, back in 15 minutes. What's the time?
It's 1/4 the hour now. So at 1/2 the hour, we'll come back, David.
4:30. Good. Okay. You'll need to join when it asks you. So, I mean, Trevor, do you want me to do this bit, or do you want to do this?
If you,
Okay, so let's hear back from the groups. Doesn't matter which group you're in. And we're not going to go through all of the groups because not all of the groups are represented here. So I just need people to say the question is, what might we be able to learn in the community? What are the opportunities for learning? And we asked you if you think about that in the cognitive domain, so knowledge, in the psychomotor domain, so skills, and then the affective domain, which is more to do with attitudes. So who would like to give me some answers?
Okay, David, may I start?
You may indeed, Dr. Kamis. Yeah.
Yes, thanks. Yeah, we had nice short conversations in our group, and we had examples from Australia where even within the same university, you might have a different curriculum between the different campuses based on the community need. So even the training in form of, or let's say, knowledge and skills can even vary. I just raised an issues comparing two different experiences, teaching in UK, where they more focus on the primary care. Okay, I teach max fax in dental schools. So a lot of focus was mainly on managing the essential diseases. Coming to a country like UAE, where you have multinational community, where the demand and needs of the different communities of more than 200 nationalities, they live in the same place, is very, very variable. And that makes a lot of issues in setting up a community-based curriculum. And a lot of graduates, they found themselves being trained on a lot of things which they don't see it on when they go to practice. For example, if you practice in Dubai, it's not like you practice in Sharjah. If you practice in a Bosch clinic in Dubai, mainly you might be doing aesthetic stuff like Botox, these what we call dental veneers or contact lenses on teeth and those, okay? All these things are not the main focus on dental schools. Okay, because all the curriculum coming from main international university were more focused on mouth cancer, prevention of diseases, and primary dental care. But when the graduates find themselves in a Bosch clinic where they have to meet a demand of a different society, and just remind everyone that those people are not the kind of patient they come to the teaching hospitals. Okay, so that's what's one of the challenges, and will make the curriculum development and assessment is always tricky.
I think you're very right. That whole business about being so context dependent is important. And of course, if you're thinking, as many of us have to, of a whole program, then there is a real question about what do you do about the students that go there as opposed to the students that go there. How can you be reasonably confident you're assessing the right things? Two people raised their hands. Dr. Layla, you've raised yours, and I'll ask you first. So do you want to give me your answer?
Hello, hi everyone. It's a pleasure to join you today. Long time no see, as they say. I was fortunate to be with two medical students actually from Sudan, where one of them has conveyed her concerns in regards to them being very different than everywhere else in the world. I couldn't actually share with her my personal experience when I had to actually go into the community, because to me, the community might not be, as everyone else refers to it, as the less fortunate people. But to those medical students coming from Sudan, they actually are training in a tertiary center in the capital city. And to them, going into the community means going to areas where healthcare is very scarce. The people in Sudan are very active when it comes to seeking medical attention. So it's actually very enlightening to know that people from that part of the world actually think that going into the community is to serve the unfortunate part of the whole country, where the medical services should not or will not be as advanced as everywhere else in the capital city. So that's their perspective, and it was very interesting to know. And when we came to the conclusion of what has she learned when she went back to the community, and she says, well, I've learned that I need to convince those people, I need to work much harder in actually explaining to them how the medical professionals can aid them in different aspects. So to me, coming from the United Arab Emirates, having the privilege to actually train abroad and going back to actually also still working at a tertiary center, it's very interesting to know how different even Arabic parts of the world are to each other. Thank you.
Absolutely. Thanks, Layla. Yeah, Dr. Mohammed, you've got your hand raised.
Group 2.
Yes. The feedback that comes from my students who get their training in the primary healthcare centers in the community, that it is a much safer environment for them to try to practice what they have learned in the lecture halls and in the simulation lab. So they feel more, it's safer for them to have some kind of conversation with a patient and to conduct also physical examination under supervision and get feedback on how they performed. So they feel that they say this repeatedly, that this is the best clinical rotation because we get the opportunity of practice in a safer environment. Another thing that considering the presentation, how patients present, they present with undifferentiated problems. So the first contact of care in the healthcare system. So it's an opportunity also to check the clinical reasoning, that how the students are thinking, how are they processing the information they are gathering from the patient and linking this to come out with some kind of provisional diagnosis. Another aspect is understanding the social determinants of health. When you send students, for example, we send students for family visits. It's now conducting over the phone, but in the past, they visit the families in their homes and they can see how, for example, a family with a patient, a child who's have diabetes type 1, dealing with this disease, what are the constraints, what are the challenges? They have a total different, they view it from a different, a new angle.
Thank you. Arena, is your...
So these are some of the things that we've discussed in
Thank you very much, Dr. Mohammed. Arena, is your comment about that area?
Well, I will try to be structured semester student. Well, in terms of cognitive domain, when you're in community, you see the real diseases that are prevalent in a local setting, which is important for the students. And sometimes there is a different equipment and different medications available at different clinics, in big city clinics and rural clinics. So the doctor has to be prepared to work in different conditions. In terms of psychomotor domain, like me personally as a student, I got much more experience practicing in a small hospital, because in big cities, patients don't trust students and you don't get so much of hands-on experience. And speaking about affective domain, I would say that there is much more drama going on in big hospitals, but if you're exposed to rural and community clinics, you see how the real physicians work there, and they sometimes can become great role models. And unless the students see this, they would not want to practice in that setting. So for me, such type of exposure is very important. And also you can experience different perception of a medical profession by the population and different attitude to doctors, which is really valuable.
Thank you. Very good. As Dr. El Hadi, you've been waiting a long time. Thank you.
Okay, thank you very much for this very nice, very interesting session. I am Hadi Miskin. I am from Sudan. And thank you, Layla, for the nice word that I am one of the students that you talk about. I am graduated from University of Jazeera as a first school in the Middle East or Africa to adopt community-based, community-oriented medical education at that time. And it is very important for us now as teachers to touch the community-based medical education in our curriculums, or even to shift totally for community-based medical educations. Once I have been trained in the community, in the health center, in the family practice, in the rural hospitals, in the community, in the camps, refugees camps, and so on. Fortunately enough, I shifted when I shifted recently to work in Saudi Arabia, University of Pisha, and I have been female fellow. My project is about community-based medical education and the possibility of adoption, some module of community-based medical education in the current curriculum in University of Pisha. It's that when I raise this issue for the administrations and the faculty staff in here in Saudi Arabia, they are very interested and very motivated to do that in their curriculums. And I apply this for female fellowships. And now we are working in comprehensive community curriculum update and curriculum update toward community-based medical education. And many domains of community-based medical education has been suggested to be applied, and we are working on it through community-based medical education unit, which is established under my supervisions. It is going well. And in term, let us to return to our subject in term of the domains. It is very important for us as a teacher to ensure that all the three domains of learnings, which include cognitive thinking, affective, emotional, feelings, psychomotors, physicals, and to be achieved through the curriculum, whatever community based or it is other type of curriculums. Thank you very much.
You make a very good point about the importance of knowing everybody knowing what the curriculum is and what can and cannot, or can and must or should not be delivered in the community. Dr. Giotti, you've waited a long time. Have you got something you can say in a minute?
Yeah, thank you so much. And I'll try to be quick. I'm here to talk about a best practice we follow in our university. I'm from the Department of Community Medicine. I'm a faculty. And there actually what we follow is, we all know that health is multifactorial. And just by seeing people like patients who come to the clinical department, the students don't really realize the importance of that, that health is actually multifactorial. So what we do is we take them to the community, like in groups, small groups, 30 to 40 at a time. And they are over a period of 2 months. They actually visit the community every day. And they identify the problems prevalent there, the health problems prevalent there. And they talk to the elders in the community. They try to understand the health needs of that community, arrive at a community diagnosis. And not only that, at their level, they plan some feasible interventions. So of course, under the guidance of the faculty. And they try to intervene by giving some health education to the population. And basically that is how we train them and give them exposure to the community. I'm from India, by the way.
Yeah, excellent. Thank you very much indeed. Trevor, over to you again, my friend.
Thank you. What absolutely wonderful discussions there. Absolutely wonderful discussions there, and I'm really pleased that they came over in the way that they did come over. There's a couple of points, I think somebody mentioned right at the very beginning about community needs. One of the things that we recognize in a lot of universities is they don't understand the community needs because they don't get out of that ivory color. And it's lovely to hear that people are now moving away into the community, as our last speaker said, and creating those opportunities. You've actually got to, as a, you know, the old quotation, you've got to be in the real world to understand the real world. And it's an interesting discussion about sending the students to only the posh clinics or exposing them to the posh clinics or the high fidelity clinics or whatever. The worst thing I think you can do to a student is to protect them from that real world, because that's the world that they're going to operate, to action in, to work in, to live in, particularly if they developed into a community physician. That's the real world that our students should understand. I find it very difficult when universities adopt a curriculum from another country and use that curriculum only to teach their students. And believe me, I've seen many examples of that. It does not equip your student. In fact, it embarrasses your student. It makes it hard for the students then to fit into that real world. So I do love this concept of exposing the students to the reality of the real world. And the reality of the real world is not good. It's not good out there. And if you protect your students by keeping them away from that, then I think you're doing them a disservice. I did like the discussion around the Sudan, because I think it's okay to be different. I think it's okay for students to realize that if you're going to live and work in the Sudan, and both David and I have worked and taught in the Sudan, that it's a different place. All of these communities are context derived. They have different contexts, and it's the students who have to, I think, understand those different contextual environments, particularly if they're going to work there. Yeah, I don't like sometimes the way that some universities say, well, really, we're going to work towards a USMLE so our students can go to America. That's not very good for the country, but you often see it. It is a safer environment, and I'm not quite sure whether it's safer, but it's a more solid environment from which you learn from. And I like when somebody, and I can't remember who said it, talked about role models. Again, role models do come from the community as much as they come from the hospital. And I think personally that role models that come from the community, and this is my bias and I apologize for that, is actually better than sometimes within the big tertiary hospitals, which have high resources, lots and lots of money. That very often is not the real world. It's not in the context then. And I did like that last comment, health is multifactorial. Of course it is. You've got to learn more things. I think there are four, before we move on quickly on to the next one, I think there are four concepts that we have to understand. Community orientated is all about understanding community health. It's a very old structure where you attended public health lectures and primary care lectures in the university, but didn't see it in action. And I hope that majority of medical schools have moved away from that now. Community-based learning, which is something that we all should be doing, is actually learning medicine in the community, learning the real world. If I give the example of the UK, which I think may be similar to other countries, if I want to learn about asthma, diabetes, hypertension, chronic non-infectious diseases, I can't learn it in the hospital because people in the UK don't go to hospital with that unless they're seriously ill with complications. Most of it is done in the community. So it's all about also this community-based learning is about learning medicine in the community or learning healthcare in the community and in those three specific domains. Community engaged learning is that something we're hearing a little bit now more, and that's working with the community to improve health. In other words, this is the students working in the community, operating, you know, as a student within NGOs or with self-help groups and with little other types of healthcare support groups to actually improve health. So students working in there has been shown to actually improve the health of the population. Very often, the whole concept of health professions education equates to the patients. Those countries we know now with good healthcare educational systems have better health parameters. And then there's the third one, which is community sensitive learning. The community shapes the learning. So if you've got a community where a major problem is type 2 diabetes, and the way that society has grown and type 2 diabetes has grown that society, then it's important to shape the students' learning to recognize that. You don't just keep them on type 1 diabetes and the rare types of diabetes. That's the most important. If they've got a high incidence of heart disease in that particular area, I live in an area of in the northwest of England where most of our problems are nutritional. The patients and certain part of this northwest of England are so poor that they do not eat well, which then causes health problems. I can't protect my students from that. I shouldn't protect my students from that. They need to know that. So the community is there to learn from, and I hope we've all now realized that that's what we're talking about today. The whole of this conference really, though, is about assessments. I think this last part of our session, I think we probably will go maybe 5 or 10 minutes over, if that's okay with everything, is to explore the assessment opportunities. So if you know what you're going to learn, or the students are going to learn, how are you going to assess that? Are you assessing it in the community, or will you assess it within the hospital? Or is it a combined assessment? So how do you use what the students are learning, and you hope they're learning in the community? How do you assess those? And again, think if we're going to go into the groups for a shorter while this time, aren't we, David? Think of using the 3 learning domains again, and maybe a group just takes one learning domain, not the cognition one, because that's easy, but the psychomotor and particularly the affective domain. How can you assess the students' affective knowledge and approaches, etc., by using the community? So shall we move again, David, into the breakout rooms? How long are we going to give them this time?
I don't know what the time is. Well, let's just take 5 minutes in the groups.
Okay.
You think 5 minutes, and then come back and talk. So
Yeah.
You'll need to move very quickly. You're in different groups again because a number of people have left. So you'll need to join the room as you get the invitation.
Right. Do you think everybody's back in, David, now?
Mostly.
Yeah, I think we'll start because we are running a little bit over time. But I think that reflects the fantastic discussion that you've had. And I apologize. I think we will go over a little bit. You know, if there's anything that you take from this, it's just about thinking about the community. David and I probably could have run a 3-hour session on this, and we would have had a lot more final conclusions. But even if it's just opened your eyes to the potential of community, then David and I are very, very pleased. So we're not going to go through the groups, but if I stop sharing for the moment, let's just hear from different people about whether they think there's any opportunity for assessment of the student and how would they do it in the community.
May I elaborate, Doctor?
Yeah, of course you can.
Okay, thank you. First of all, I'd like to thank you and also the doctor for both of you actually for the session, which is very fruitful and productive. And you tackled a very important point about community, because as you said, it is neglected by many healthcare providers, the standard of care in these areas. So it is very important to have a framework for a standard of care regarding, for example, affective domain, a psychomotor domain, and the cognitive domain. Cognitive domain is difficult here because actually the patient is unknown for the doctor, because it is not like a hospital. You have patient history and everything documents. But for example, in other setting, you need also to have a sense of analysis beside knowledge. So this is should be considered during preparing a frame for cognitive domain, giving percentage for analysis more. Also, a rubric should be very detailed information about the rubric that will be used for assessment, including, of course, activities that should be done by the students in these areas. But besides these activities, we need to have a very detailed rubric to be assessed by at least 2 reviewers in order to ensure the consistency of assessment. And as you said, it is very important not to neglect the affective domain, because we have different people, for example, disabled, marginalized people, women, minorities. So they need also to have equal standard of care. So when we adjust this assessment procedure, it will also help us in having a reasonable argument and reasonable discussions about the way of setting such a framework.
Thank you. I think, Osman, that's great. I think there is opportunity. I think there are, sorry, get my English right today. I think there are opportunities for all 3 domains to be assessed. It's just trying to find the right way to do it. And I think Dr. Osman has put some incredible ones there: assignments, community satisfaction surveys. I'm not quite sure what you mean that by, but if the students learn by constructing those, that's brilliant. Psychomotor by logbook, yeah. Let's use those people within the community to observe our students doing the right thing to the right people in the right way. The formative assessment is becoming much more stronger than summative assessment now. And remember that students learn from formative assessment. So great feedback is crucial, as David says. Books on documentation, clinical social case discussion, absolutely fantastic. Arena, reflective diaries, peer assessment, interesting peer assessment. Who said that? Dr. Gada. One of the problems that we have to have, we know with students and peer assessment, is that they either tend to over-assess or under-assess, or overrate or underrate, and it's not always good. Near peer is better. So senior students and junior students being together in the community, learning from each other and assessing each other, is a much more closer to the reality method, I think. Field report with tutor assessments, great. I think there's a nice one. I can see Dr. Shuba's got a hand up, and so Dr. Shukri as well. I'll come to you in a minute. But Rania says we can also assess the affective domain through observing how the students act in the community. And again, you've obviously got to have somebody there. But remember, there's no reason why we couldn't apply 360-degree assessment, multi-feedback assessment within the community. Just because we don't do it isn't inappropriate. We can do it. So I think, as Dr. Awa says, beautiful idea, Rania. That's great. Dr. Shiba, you've got your hand up.
Yeah. Good evening, sir. Sir, affective domain, usually the measurement of affective domain is very difficult and time consuming. But I think when we measure the learning outcomes of the students, it's never complete without measuring the affective domains also. Because when we try to assess the affective domain, we should that should include the assessment of values, behaviors, and attitudes of the students. So measuring them is little, quantifying them is little difficult, but I feel like we can have the guided reflections, and they can keep some reflective journals And maybe again, patient surveys, like whether there was any difference before and after, something like that.
Yeah, I think Dr. Sheba, you're right. I think I really do enjoy reflective diaries, as long as the students know what's in that reflective diary and how it would be used, and you've got the right person looking at them. I think they're great for formative feedback. I think
guided reflection.
Yeah, guided ones. I think sometimes when we say, oh, it's so difficult, the danger of that is we think it's so difficult, we never do anything about it. But there's enough written now within the publications that show us that we can effectively assess the students in the affective domain by many methods. So we shouldn't just push it on one side because it's difficult. Dr. Shukri, you've got your hand up as well.
I am sorry, I am interrupting.
Hi, Hassan.
Yes, because for two things. First, to thank you, Trevor, and thanks, David, for accepting, of course, our invitation and to join and to give this great workshop, which, as you can see, the attendance is amazing. And so far, we have 3,000 who have registered and approximately 1,000 in these workshops of today's workshops. And when I was just passing and looking, and then I found a very dear and close friend whom I didn't see him for some time, and maybe it's my problem, but Professor Sami Azer, I see him there, and Sami, I really miss seeing you and having our discussions, and I am following the great things you did it in Kingdom of Saudi Arabia and all over the world as usual. So I am very, very pleased to see you today participating in this conference. And I see, at least on the screen next to you, Ibrahim Bani, but he's not far from me, and definitely he can come. And Shadi Hamouri from Irbid, Jordan, very close friend, and others.
Dr. Hussein, Maha, yes, from Beirut Arab University, Lebanon.
Hi, Maha.
Hi, doctor. Hi, doctor. Very pleased to see you today. Really, it's very, very interesting conference. Congratulations, doctor.
Alhamdulillah. Professor Sami, please, we need to talk, and it will be a great honor if you come and visit me here in UAE, and it will be really an honor for me to have you with us here. So thank you very much for attending this conference.
Thanks, Hassan. We'll go back. I still want a couple of points to make.
I come out, and then I will have a separate discussion with Dr.
All right. Thanks, Professor Hamdi. Yeah, I don't want to miss some of the points, some of the great points that people have been bringing up. You know, Jahansi, Dr. Malay said, how about assessment with attitudes by virtual patient encounters? Yeah, that's great, but make sure that you use it as a community encounter rather than a hospital bed encounter. You know, it's using them in the correct way. And there was somebody, yeah, the 4 components of the EPA does include product evaluation, Dr. Gather. That's great. So, you know, there's a lot of things, and as I said, I apologize. This could easily have gone into a 3-hour talk that we do. Dr. Shukri, I know you've still got your hand up, love. Do you want to quickly say something?
Yeah, yes, I will. I know the time's up already. I just wanted to say, I mean, like, first at all, I would like to thank you, both of you. and you made a very important point, which is the community and how I actually teach the master in a community health usually. So I understand what you mean. When I was in the US and doing that kind of home visit, seeing the patient, all these things, it's totally different in now what we do. If I go back to our assessment, usually how we do the assessment, it is student course portfolio. So through that, there will be, and also our course syllabus has cognitive, which is the knowledge testing, and then we have skills, which is psychometer, and then we have affective, which is the attitude, how they are doing that. So the end of the semester, we usually evaluate. There is assessment, continuous assessment, like case presentation, attitude. Also, we see when they will do home visit, how they are dealing with the situation, and also we try to them to do journal of reflect. So that one also we do. So that's just one I want to share with you. This.
Thank you. Dr. El Hadi, you want to have the sort of the last say almost?
Okay. I want to add. Hello, you hear me?
Yeah, we can hear you. Yeah, sure.
Yes, I want to add that in community-based medical education, it is very motivated for student as well as for the community at the same times. And we will always utilize behavior of awareness, or interest, or attention, and responsibility. And also we interact with the community member. And this is very interesting community of learning at the same times. As the last, I want to thank Group 6, Prof. Shukriya and Prof. Ranjo for their discussion with me before to present my talk. Thank you.
Okay. Thank you, Dr. Helati. Well, I'm looking at the time, and I know people have been on into the conference for a long time and probably are very tired and maybe even very hungry as well. So we will stop there. It is absolutely wonderful to see such wonderful people around the world and some good friends that I like Professor Hamdi that I haven't seen for a long time. So again, a big thank you. I think if anybody came and thought, well, I'm going to learn everything I need to know about community-based education and assessment from David and Trevor, sorry, you were wrong. We couldn't do that because it would take us an awful long time. And that's not the right way. I think what we wanted to do, and I feel as though we've been successful in that, is just open your eyes, open your brain, open your thought processes to the potential of the community, which in many parts of the world, we don't tap into that potential. It's got tremendous potential. We don't tap into it. We keep ourselves within this ivory tower. It is wonderful, though, to hear so many people saying that you're already trying these things out. And I think we've got to do that. It's about being in the real world. And I hope David and I have opened your eyes to the potential in that real world. So a big thank you from me. David, do you want to say something?
You're muted, Dr.
David, you're muted, my friend.
I've got to the stage where I can no longer learn new tricks. We've been talking about community in one sense, but of course we've got to remember this is a community as well. And so do remember to make a note of the people that you want to talk to and get in touch. It's the most important thing about a conference is the networking. It's so hard when it's an online conference, but it is still possible. And you've got access to us through the program. And actually we'll the thing's being recorded and we've got more sessions tomorrow. So make sure that you do get in touch with people, ask them, and feel free to pester and I've really enjoyed it, and so thank you very much.
Yeah.
And it's good to see so many people that I know. It's lovely.
Yeah, and I think that brings us to a point of this community of medical educators. If we don't use that community, we sink. We've got a great community, an international community of medical educators, and we all work much better together. I just wish some other parts might work a little bit better together, but no, we've got great. So I again just second what David said. Thank you. Hope to see you in tomorrow's part of the conference. Please take care, everybody, and stay very safe. It's wonderful to see you. I don't want to lose you, so stay safe. Bye-bye. Thank you.
Thank you very much, Professor Trevor and Professor David, for really enlightening session. We really want to put our shields and tools and jump into community, because we really need to be in the real world to understand. Yeah, we are ready, or hopefully have, as you mentioned, open our eyes to the different possibilities of learning in the community and how we apply that in our practices. We're really looking forward for tomorrow's session, tomorrow's conference session. Thank you very much, everyone. It's been a great pleasure. Thank you.
Thank you, Emin.
Thank you.
Take care. Bye-bye, everyone. Bye-bye. Thank you.
Bye. Bye-bye.
Okay. Thank you.